Yeah, so I'll talk to you more about the pregnancy changes and what can bounce back and what happens from there. But yeah, so now I'm working at Point Physiotherapy in town. It's on Park Avenue. So I've got cards and things like that if you need any of those. But yeah, otherwise we'll get started. I'm so loving that you're the tech person because I'm like,
they're going to kill me if I'm not recording. Yeah, it is. Yeah, I'll just. Oh, good. You can see. Oh, because it says stop recording. Yeah, I know.
oh no, that's the share. That's the screen share. Oh no, yeah, you can see the little dot in the cloud.
Yeah.
I don't know why I can see it there. Perfect. Okay, cool. So
Nearly forgot to record.
no, you remembered at the perfect time. So I thought we'll go through just a very basic understanding of the pelvic floor and its role, and then we can talk more about what happens afterwards. So on the screen, I've got 3 different pictures. I often will use the side-on picture just so that you can understand where things are in space. And then this middle picture is looking down at the pelvic floor, and then this one's looking up from underneath. So to simplify the pelvic floor, because it's quite a complex structure, we talk about 2 different layers. So we've got the deep pelvic floor and the superficial or the outer pelvic floor. So this middle screen, the middle picture is looking at the deep pelvic floor, and then this is the outer. So if you think about the 2 layers, the outer layer is the sphincters around the bottom of these 3 hoses. So you've got your urethra that comes down from the bladder, the uterus in the middle and the vagina, and then the bowel and the rectum. So the outer pelvic floor acts as like a little sphincter, a closing sort of mechanism at the bottom. There's a sphincter at each one. So they're responsible, yeah. So you can see them here, the little round muscles here. So you've got to not get too technical, but you've got an external sphincter around the anus, and then around the vagina, and then around the urethra, which is the tiny little exit for urine. So they're responsible for 30% of our urethral closure pressure. So the deep pelvic floor then is responsible for 70%. So when we give birth, if I get up, people won't see me, but that's okay. When we give birth, obviously baby's coming out of here. So this dilates to hopefully 10 centimeters. And this part of the pelvic floor, this is your levator ani group, that gets stretched to 4 times what it needs to be or what it normally is. So if you think about a hamstring or a bicep or something, any other skeletal muscle, if you stretched it that far, it would tear. So there's generally some sort of at least a grade 1 tearing or some grazing in the back portion of the pelvic floor. Anyway, we'll come back to that. But what the pelvic floor does is it holds the pelvic organs up. It's responsible for sexual function and obviously bladder and bowels and things like that as well, release and contract, obviously, to keep you continent. But if we talk about these pelvic organs, I like to talk about it with a bit of an analogy. So if we hung one of these Swiss balls, the big gym balls from the roof, and we suspended it with some of like the elastic bands that we use in Pilates, over time, that ball is going to drop down just because of stretch. Does that make sense to everyone? So what the pelvic floor does is it comes in and sits underneath the ball and holds it up so that there's not so much stretch on those rubber bands. So to bring you back into this picture, the ball is obviously your uterus and your bladder and your bowel as well. There's lots of ligaments in our pelvis that suspend all of those up. Over time, age, gravity, and just life, they get stretched as things drop down. You get pregnant, you have a huge weight on your uterus, it presses down. You can see the way it presses down on the bladder. So the pelvic floor is really important to hold it up. And then when we have pelvic floor injury or weakness, obviously we have more stretch on those organs, on the ligaments and tendons that hold them up. So in terms of continence, this deep pelvic floor group that attaches from the tailbone, the levator ani group. So levator being lift, ani being anus. So they all attach here at the tailbone and they lift up. And the way it contracts is it kinks the hoses. So you can see the way that this part of the muscle lines up. When it contracts, it lifts this way. and it will kink the hoses. So these guys are at the end of the hose and they stop it right at the end, but these muscles kink here to stop the flow. Does that make sense to everyone? Cool. So that's essentially the pelvic floor in a nutshell. When you are pregnant, and obviously I don't know anyone's, I know one person's history in here, but we'll talk just generally about what happens when you're pregnant, and we'll go through, if anyone's got specific questions, I'm happy to answer them. If you come up with a question as I'm going, I think Lauren was thinking we'll do questions at the end. So grab your phone and write it down because I don't want you to forget it. I won't be offended, okay? So when we're pregnant, there's lots of different changes to accommodate Bubby. Our rib cage actually expands. So you'll see young girls, they have these really cinched waists and they have this hourglass figure. Our rib cage has to expand to create more space. It gets pushed up and the diaphragm actually lifts up and gets compressed up by about 4 centimeters at full term. So when you're normally breathing, your diaphragm descends and contracts. And so obviously over time through pregnancy, it gets less and less able to do that. So we get more and more breathless because we can't get as much breath in. We then go into not so great breathing strategies in our neck if we're not educated on where to breathe. So we're trying to train people to breathe into here a little bit more with pregnancy. But then that can cause a whole other issue in terms of things like nerve compression down through the arm because we're breathing with our neck muscles to try and get more air in. So some of the things that we do in Pilates and physio is to try and work on an optimal breathing strategy to prevent that because you can end up with carpal tunnel and things through pregnancy. So that's the rib cage. And then we come down to the pelvis. Pelvis widens, obviously, as the hormones affect all the soft tissue and muscle around the pelvis. You start to widen. And of course, when baby is delivered through, you have a rather large structure going through what was quite a small opening. So as you deliver Bubby, you have enough relaxin and hormones to let the tailbone open, and then the pelvis itself widens this way. So sometimes towards, and it can be early in pregnancy as well, but sometimes as the soft tissue between the front bones of the pelvis loosens, we can get like a friction, and we call that pubic symphysis syndrome. And so it's like a friction burning pain in here, and a lot of pregnant women you'll see they won't be doing lunges if they're having issues there. Some women will do lunges right through until the day they deliver and they're completely fine. It just depends on the body. Some women will end up with sacroiliac issues, so sacrum ilium, so they'll have an issue between the joints here, again from laxity and lack of support. So we'll talk more about the importance of things like Pilates and strength work for all of those deep muscles around the pelvis. Something I see a lot of is girls who were sort of, what's the word? Not cheating, but piggybacking and using all of the ligaments around the pelvis to keep it supported when really they should be using the muscles and keeping strength in there. When they get pregnant and they lose that integrity of the tissue in like the ligaments and the what should be the backup support, they're supposed to be then relying on the muscles, but if the muscles aren't strong enough, that's when we start to see those problems around the pelvic joints. So then we come down to diastasis recti, and this is something that I don't think is spoken about enough. Every single woman will have abdominal separation through her pregnancy. We have to accommodate a baby's growth. So you will always see this linea alba, the central part of your abdominal wall, has to soften and expand. So if you feel what we would call a nullip or a nulliparous woman, so someone who's never had a baby, her linea alba will feel like fiberglass. It's quite strong, or your husband, for your husbands, depending on how much tissue, extra tissue he's carrying. But you'll feel that it's like fiberglass. It's a really hard structure. And then through pregnancy, it softens and becomes really jelly. And you can sink your fingers into anyone who's fairly freshly postnatal or late pregnancy, and you'll feel there's almost nothing there. You can almost feel pulsating of the organs underneath. So yeah, and so that's why we've got to be careful towards the end of pregnancy with what we choose exercise wise. And I'll talk to you more about that. I've got sort of a specific slide on each of these as well. So and then you can see in this picture here, your lumbar curve changes because baby gets heavier and heavier, we tilt the pelvis forwards, we increase in the compression in our lumbar spine. And so if there was any, again, lack of muscular support or underlying disc problems, they're going to start waving their hands and let you know at this point through pregnancy. There's lots of other changes, like your blood volume will increase very early on in pregnancy because you're now feeding a placenta and a baby. So you have heat, you're thirsty, you drink a whole lot more water, but you also wee a lot more. And a lot of women, you know, they're like, I'm not even showing it. I don't even have a baby, you know, I don't even have an obvious baby here yet. And I'm, you know, getting up 3 times to go to the toilet. And that's why, is because their body is just making so much more blood to try and feed Bubby and grow Bubby. So that will also bring into consideration things like varicosities. So you'll see a lot of women get them in their calves, but you can also get them in your vulva, which is the tissue around the vagina. So really uncomfortable, really painful, and there's lots of ways we can manage that. Constipation is a big one to think about with pregnancy and then postnatally as well. But because of the hormone changes, the tissue in the rectum, I haven't got that picture anymore, but the tissue in the rectum, it usually squeezes and relaxes and squeezes and relaxes, and that's how we move food through the bowel. That all softens and doesn't happen with as much strength as what it normally would, and so our digestion slows down, and if we end up constipated and we're straining, we're adding more pressure onto the pelvic floor and the pelvic organs, which is something we really, really, really want to avoid when we're pregnant, because there's nothing there to support you, or there's less to support you than what there normally would be. And then of course you've just got the physical, mechanical pressure on the pelvic floor. So that picture before, your uterus sits on top of your bladder normally. So as the uterus gets heavier and heavier, bigger and bigger, the bladder can cope with less and less pressure. And so for all of these things, exercise is really important. And any patient, any friend, any family member of mine that gets pregnant, even if they were running marathons or going to the gym 3 times a week, I make sure that they start some Pilates really early on, because it's such an important and a really helpful way to exercise all the way through. But it just focuses on all the right things for pregnant bodies. So obviously we're talking a little bit more about vaginal deliveries today, obviously because we're talking about pelvic floor, but even a body that's had a cesarean delivery has still experienced a pregnancy. So all of those things I just talked about are still considerations for a cesarean. But if we come in and talk about a vaginal delivery, there's lots of things or factors that will sort of add to risks of prolapse and risks of stress incontinence and things like that. So this is some of those things. It sort of sounds a bit scary and negative, so I apologize for that, but we will come back with some smiley faces at the end. I know, Teresa, it's sort of like, it's important to know, but don't get too scared. So I know, come and sit next to me, I'll give you a cuddle. No, it's so worth it. I'm going to start with like sort of the 2 most common things that you will see. And episiotomy is what the doctors will perform if they think there is a risk of tearing, if they're sort of looking at baby's head and how much dilation is happening and how fast everything's moving. They'll perform an episiotomy, which is a little snip of the pelvic floor. Now, they used to snip straight down, but if you think about, if you were to snip, say, a bed sheet, that point is now at more risk of being torn if you pull on it. So they've realized that they need to snip on an angle to prevent anything happening down through to the anus, because that is also quite a big risk in a vaginal delivery. So if we talk, and an episiotomy can be stitched up, and within 6 to 8 weeks, a woman, you know, most of the time won't even know it's still there. There's some women that have more pain messaging through the brain, and that's a whole other topic, but there's some women that will still experience pain for up to 6 months. But it just depends on the body. So when we talk about tearing or grazing of the pelvic floor, they grade it. This is actually a slightly older grading scale, but I just really liked the pictures. So the first degree, we sort of go first degree, second degree, and then a third degree tear is now split into A and B, and then a fourth degree. So first degree, you'll just see some what they call grazing in the perineal skin. So it's actually not torn any muscle, it's just the skin. They'll call it grazing, you'll get an ice pack, and you will probably be fine in the next couple of weeks. You just need to take it easy and be kind to yourself. There's lots of things now that they use, like different oils and things like that to help with the healing. But usually that won't affect continence, prolapse, anything like that. Second degree tear involves the skin and a little bit of the perineal muscle. It hasn't moved. So this little star is your anus, this is vagina, and that little dot at the top is your urethra. A second degree tear, you can see, moves through the skin and a little bit of the muscle, but it's not affecting anus at all. So a third degree tear, they now split into A and B. So 3A doesn't involve any of the the anal sphincters, and a 3B does, whereas this old picture doesn't quite help with that. But so 3A comes down to the skin around the sphincters, 3B affects the muscles. So if someone comes to me for their postnatal assessment and they say they've had a grade 3 tear, I need to know if it's A or B, basically. So that will really affect their continence in terms of fecal support as well as urinary. A fourth degree tear comes all the way through to the muscle of the anus as well, and we will unfortunately be looking at some fecal incontinence. So obviously we'll be managing that slightly differently to the urinary continence. They will stitch up tearing as best they can, and there's other surgeries further down the track that you can look at as well with the obstetrician gynecologist. However, pelvic floor muscle training, and there's a few other things that I'll talk about later, are actually massive in terms of healing here. And I've seen lots of women who have had 3B tears and they've not had to go in for surgery because they've just rehabbed it with physio. So surgery is helpful at the end of the line, but it's not really the first option if it doesn't have to be. So obviously the grade of your tear will contribute to risk of prolapse, risk of continence issues down the track. Instrumentation is also one of the biggest indicators. So we're trying to move away from forceps as best we can. Forceps has a very strong link to prolapse and incontinence. Vacuum, not so much, but it's obviously not as strong as forceps. And depending on, like, I've got lots of different ages in here, but depending on who you speak to, forceps would have been the first thing that they used back in the day. They would have gone straight in for an episiotomy, straight in with forceps, because that was what they knew back then. And now we're lucky enough to have a lot more research to sort of say, well, you know, let's look at other options first. And I educate a lot of my pregnant girls on that and sort of say to them, look, I went in and said, if possible, I would rather go for an emergency Caesar than to have the forceps, because I've seen the research on the strong link between forceps and prolapse. So there's a lot of countries in Europe that don't use forceps at all. They've completely just stopped it because of all the new research, but Australia tends to be a little bit slower, unfortunately. But we're getting the research now, so we're going to work on it now. So levator avulsion is something that a lot of people have never heard of before. If I go back to, yeah. So levator muscles, the levator ani group, this deep group here, and they all attach to the front of the pelvis there. So you can see there's a little gap at the front. A levator avulsion is when the muscle avulses off the bone, which means it's torn off the bone. So we use this little model to help understand that. So if you think this is the urethra here on this model, I'll do this down here in a sec. Yeah. So when we palpate, when we feel what's happening, we feel muscle, 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 and then nothing here. So I'll do that for the girls on the screen as well. So this is urethra, and then this is the back of the pelvis here. So when we palpate, we feel up and around and we feel muscle and then we find where the muscle has fallen away and we just feel nothing. So you can feel that in your own pelvis if you've got the dexterity, but obviously that's what we assess for when we check women at their 6 week, or any point really, because a lot of women haven't had their 6 week check and I'll see them 40 years later and I will still assess for that just in case. Exactly. So you can avulse anything. I avulsed one of my calf muscles off my ankle. You can avulse things in your shoulder. So it's when the muscle is actually stronger than the tendon, and instead of tearing the muscle, you tear the tendon off the bone, basically. So yeah, and unfortunately it has really not great consequences in terms of continence, but again, I'll talk you through what we do to manage that as well. So pudendal neuralgia is really common postnatally as well. It's just when there's a neural injury in the pelvic floor. So the pudendal nerve serves pelvic floor and bladder, and usually there will be some sort of compression or grazing of that, and women will lose a bit of feeling or a bit of neural control around pelvic floor and bladder. And some women that lasts a couple of days, some women that lasts a little while. Usually it's gone within the first sort of 6 to 8 weeks. Obviously it's hard because everybody and every pregnancy and every delivery is different, but we sort of give vague numbers on things like that. And then obviously when we see you one-on-one, we can give you more specifics. So optimal birthing positions is another thing we try and educate women on, is being upright rather than being on your back. Because if you think about the way the pelvis tilts, you've got to then push a lot harder to try and get the baby up and out of the pelvis if you're lying on your back. Whereas if you are upright or in a forward bend or in a squat, baby's got a lot more space to get out. Can you see that on the screen, girls? Do you know where that came from? Henry VIII. He had people come and view the birthing of his wives, and it was easier for them to see what was happening. Yeah. Anyway, so yeah, that's right. So I'm teaching all of my girls, get on your hands and knees, get in a squat, like lean on the wall, whatever you need to do. And if actually, guys, if you need to get up and move, get up and move. I won't be offended. I hate sitting, so I'm the one at the back of the room stretching, and yeah. So early postpartum period, we're sort of looking at the 6 week mark before you go back to see your doctor or obstetrician, and then hopefully women's health physio, is just focusing on tissue healing, regardless of if you had a little bit of grazing, a bit of tearing, an emergency Caesar. It doesn't matter. You are just taking it easy. Try and get your feet up, try and get your pelvis up, to let everything sort of sink back, work against the pushing that you've just been doing. The tissue around our pelvis is so distensible because we've just gone through labor. So often if you're assessed in that early stage for a prolapse, you'll have what we used to classify as stage 1 pelvic organ prolapse, but we now call it natural early, oh gosh, I can't think of it now, but it's a natural distensibility of the tissue in a postnatal period. So if I then assessed you, 6 months down the track after you finish breastfeeding, or 12 months down the track, and you checked it again, everything's resolved. But in those early stages, you will definitely have distensibility of the tissue. And that's why we say don't run, don't exercise, don't bear down, just take it easy, go for gentle walks. And depending on the girls, I always get my pregnancy girls to then email me once they've had Bubby, once they're back in, I don't expect to get the email day 1, but I try and get them to email me soon so I can sort of advise them on what they can start doing safely, depending on what happened with their delivery. But you can start to reconnect with your pelvic floor fairly soon after delivering. And then there's my quote that I quoted before: we don't bounce back, we bounce forward. So at the 6 week check, you will see, if you've gone privately, you'll see your obstetrician. If you've gone publicly, you'll see your GP. And if you see a good one, they will refer you to a women's health physio. In Europe, there's multiple countries that a 6 week check at the hospital is part of their health system. So regardless of what kind of delivery, what happened, you go back at 6 weeks, you are assessed for your abdominal separation and your pelvic floor, and then you're referred on if you need more help. In Australia, what's the 6-week check? Oh no, I haven't had that. So yeah, we're working on it. We're working on it. Yeah. 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 Yeah, that's right. So we're trying to get as much awareness out there in the community, even just having coffees with friends. But it's really important to get checked because the first 6 months postnatally is when you can make the most change and reverse most of what's happened. However, if we see you 20 years down the track, there's still a whole lot we can do. But if you had that education at the 6-week mark, wouldn't you do it? So, we can prevent having to see you at the 20-year mark altogether. So, yeah, the more we learn, the more we know. So, and I always like to, even if I see a woman postnatally at 6 weeks and I'm like, you're actually fine. You can start, building up with your gym or your Pilates studio or your personal trainer or whatever it is that they want to do. I always say to them, please come back when you finish breastfeeding, because when you're breastfeeding, you're actually really low in estrogen. You suppress estrogen, and so that has a big effect on the tone and integrity of your connective tissue in your pelvis as well. And so if there was something that we were sort of question marking, okay, is that a prolapse or is that just normal distensibility postnatally? If we then check you again later, when all the tissues sort of return to a little bit more of a normal sort of state, then we can actually say, no, yeah, it's fine, or yes, we do need to do something more about that. So I find that the 6-week check is very important. Oh, wrong button. But also after breastfeeding as well. So then if we look at the 6 week to 2 years, it's usually 2 years before women's bodies are actually, back to a normal point, or at least hormone levels are. I'm a little bit the same. I'm like, I can't take my jumper off because I got this thing on. Yeah, so I mean, like, that's sort of when women are finishing up with breastfeeding and their hormone profiles start to return to normal. Their menstruation is coming back to normal. So that's really when you want to start increasing the intensity. Up until that point, I'm getting women to walk, I'm getting women to swim, I'm getting them back into Pilates. But in terms of things like running and heavy weightlifting, you really aren't seeing a normal schedule up until that point. And like, babies don't sleep. So, sleep has such a huge impact on your strength and integrity of tissue as well. So all of that we sort of consider for the first 2 years. And then we move on from there. So I sort of talked about estrogen before. So in both menopause and breastfeeding, you have low estrogen. So we see things like less blood flow to the vaginal tissues. So vaginal dryness, that can be itchy, that can be stingy. It just depends on the body. But it affects things like your sex life, just your general comfort as well. So we're advising women on what you can use as vaginal moisturizers, but also as lubricants. And the other thing we see actually with that, especially if there was some tearing or stitching that has caused a bit of chronic pain, we tend to see pelvic floor hypertonicity, so overactivity, and a really tight and painful pelvic floor. So again, another big reason to have your pelvic floor checked, because everyone says, oh, you've got a weak pelvic floor after pregnancy. And I would suggest that I reckon I see about 40% of women after pregnancy and their pelvic floor has gone into shock drive and they're in pain. They're dry because of the pain. Because what our brain does is it cuts off the blood flow to painful areas to try and sort of protect itself. And so then we end up with dryness and we get this cycle. So again, like I was saying before, because of the hormonal profile with breastfeeding, we have low muscle tone, low connective tissue density. So considerations for what you're going to do activity-wise for that. And then I've written DRAMS here, which is diastasis rectus abdominis muscle separation. So ab separation, basically. So the latest research on DRAMS, or ab separation, is that we actually need to keep tensioning the transverse abdominis, or the linea alba, as much as we can throughout the pregnancy, and then as soon as we can afterwards. Previously, it was sort of like protect, 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 don't do anything, don't do anything, don't do anything, don't even get up out of bed properly. And I do still teach women to roll over to their side to get out of bed. But there's a lot of protective sort of exercise avoidance that needs to change, because if in the research now they will compare a woman who's done nothing, a woman who's done appropriate exercise, and a woman who's done too much, and they're actually seeing that the women that have done too much are actually better off than the women that did nothing. So we need tone, we need load in our muscles and our connective tissue to actually keep them happy. Obviously safely. I'm not going to say go and weight lift, deadlift 140 kilos at 36 weeks. Don't do that. But it's appropriate now, which is really important to know. And then return to breastfeeding. We've actually just been blessed with some guidelines from some physios in the UK. We had nothing before that, but we've got actually marks to check off, or things to check off, in terms of different measures in the pelvic floor and around the vaginal hiatus and the length of your vagina and the dissension of your organs and things like that. And then obviously considerations around how much sleep you're getting, and breastfeeding status and all that sort of stuff as well. In terms of Pilates, it's obviously not as much of an impact or a jumping exercise, but even things like walking to an intensity, or anything that involves a bit of bouncing, women need to know to breastfeed or express first. Don't go for a run or do a high intensity like a jumping exercise with full boobs, because you can actually do quite a lot of damage to the ligaments in your breasts as well. So good breast good breast awareness and good bras as well. And then, like I said before, every woman who has carried and delivered a baby is considered post-natal. So a lot of people sort of cut it off at like 2 years, but you are post-natal for the rest of your life, which is great. So I'm going to talk through a few different considerations now in a woman's life cycle. So menopause is the loss of ovarian production of estrogen. Skinnier women tend to actually, on the whole, be affected a little bit more so than women who are carrying a little bit more tissue, because fat tissue actually acts as a storage vessel for estrogen. So when we suddenly get that stop off in production, a lot of the time you'll see the smaller women that don't have that buffer suffer a lot more, whereas if you've got a little bit of storage, it sort of slowly drops off, which is quite interesting to see. So menopause, people look at it differently. It's sort of like a moment in time, and then you're postmenopausal. So at the moment, the research sort of says no one's really menopausal. You sort of, the moment that your period stop is menopause, and then you're postmenopausal afterwards. But that's me being a bit technical and basing off the research. If you told me you were menopausal, I'm not going to laugh at you. I'm going to give you a cuddle. Because I don't want to get there. No. So we get a weakening and a stiffening of the pelvic floor and the tissue around it because of the loss of estrogen. We, again, like I said, vaginal dryness, we lose the blood flow to the area. And so I've written in brackets here OAB. Overactive bladder is something we see a lot of in postmenopausal women because of that stiffness and the loss of elasticity in the bladder wall and the vaginal walls. So we have like an increase in urgency, and then we get a bit of a cycle of fear around leakage because of the weakness in the pelvic floor muscles as well. So we start to see a lot more use of like continence pads and things like that. And no, I can't go to that activity because there's no bathroom there, or I can't drive that far because there's no toilet on the way, and it becomes a real life-affecting thing. And there's lots we can do to help with that. Unfortunately, we see weight gain around the belly as well with menopause, and weight gain is actually quite a big indicator for pelvic organ prolapse. So we're looking at all these points and we're going, oh my God, stress incontinence, pelvic organs, but lots of things that we can do. I think that's all I wanted to say about menopause. I'll probably come back to something. Oh, and of course, there's things like bone density that we need to consider, and exercise is the best thing for bone density. We need resistance for our bones to stay strong. And if I look at most of these points here, exercise is going to make some sort of difference. With the urgency and overactive bladder, there's lots of strategies we can work on, but I could speak to you about that for 2 hours, so we won't go into that today. Come and see me if you need to. So I really liked this graph. I don't know if you guys have been having a look at this, but it sort of shows you how much estrogen is in your bloodstream at different ages through your life cycle. So I just really liked that picture. It was really nice and clear. The levels of estrogen in your blood and your body as you go through. I wish there was a pregnancy one in around here-ish though, because there's less. What's that? Yeah. Yeah. Wow, there needs to be a pregnancy one that's more like this in here, like not a pregnancy, a breastfeeding one in here, because breastfeeding is actually really low estrogen too. Yeah, that's yeah. Yeah, definitely. Yeah, that's right. Yeah, and often if your liver isn't detoxifying your estrogen properly, it starts to reuse, and that's why you're still getting acne at those later age groups as well. So that is another workshop as well. Liver, yeah. Yeah. Oh, cool. I'll have a chat to you later. Yes. Oh, I did try that. So, yeah, that's another one. Yeah, I'm like listing them all now. Okay, so stress urinary incontinence is what is the mechanical loss of that urethral closure that I was talking about before. So when your urethral closure pressure cannot withstand the downwards pressure on it, so we end up with a little bit of leakage or a lot of leakage depending on what the pressure is and how much weakness there is in the closing strength. So I really like this picture because it sort of shows you when, say you had the same amount of pressure going downwards, continence is when you have enough to close against it, and incontinence is when you don't have enough closure pressure and we get leakage. So yeah, absolutely. Yeah. So yeah, so there's so much we can do. Yeah, totally. So the pressures that I've sort of listed here is things like cough, sneeze, jump, squat. The biggest amount of pressure that you actually put on your pelvic floor is this. So I'm often training women, sit to stand. So I'm training my pregnant girls, but I'm also training all of my postnatal women, regardless of if you see me for pelvic floor or your neck. I'm teaching you how to stand up from the chair with appropriate use of your pelvic floor, because that's actually the biggest. Yeah, absolutely. Yeah. It's so easy. It's honestly, it's awareness. If you know how to lift your pelvic floor, every time you cough, sneeze, stand up from a chair, you have a moment before that happens to lift the pelvic floor and then counter the pressure. And I've had women who have come to see me with what is a pelvic organ prolapse, and I teach them how to do that. And I can watch them, and I'll get underneath them, and I'll say, okay, now squat now. And they've gone from pelvic organ dropping to holding it up just because they didn't know what to do. So often it's not even a strength thing. It's just I didn't know I was supposed to do that. So yeah, it's a lot of behavioral, neurological control, which is really cool. And just a little note, this actually can happen with women who haven't had babies too. So a lot of it is like breathing patterns and core strategies that aren't optimal. If they're bracing and bearing down, I give them the analogy, if you look at a sausage, if I held a sausage up in front of you and I squeeze the top of it, the bottom of the sausage casing then has heaps more pressure outwards and heaps more pressure downwards to counter. And if there's a loss of strength underneath or in any of the walls, that's where you're going to see a hernia of that casing, or in our case, an abdominal hernia or an inguinal hernia or a pelvic organ prolapse. So it can happen in a woman who has never had any sort of defect or injury to their pelvic floor. So that's part of what we're retraining as well, is breathing patterns, core strategies, movement strategies, even toilet strategies. I'll talk to you about that when we get a little bit further on. Cool. And I always say to people, leaking with exercise is common, but it's not normal. We can change it. We can definitely, if not get rid of it, we can improve it to a point where you can actually go for that drive, or you can go and do your skipping, or you can do the exercise that you really wanted and you thought you couldn't. You can chase a child without having to, Yeah. Yeah, exactly. So in terms of physio, the first thing we will always do is pelvic floor muscle training. We need to assess the pelvic floor first to know that it's either a weak pelvic floor or a tight pelvic floor that isn't releasing, and so it's fatigued, because there is a massive difference in how we would approach that. So again, stress urinary incontinence isn't always a weak pelvic floor. It can be movement strategies. It can be that you've got an overactive pelvic floor from other issues, like things like constipation or IBS or lots of other things. And we actually need to teach it how to let go so that it can be used appropriately. So if you think about, if you were holding a really heavy weight in your arm like this all day, your bicep is on all day. And then all of a sudden you've got to pick something up real quick. It's tired. It doesn't do it as well as what it could. So we actually need to teach the pelvic floor to relax when it's not needed, so that it can switch on when we need to sneeze or jump or whatever it is. So it's really important to get assessed first. We look at things like bladder diaries in case people are just drinking too much. The whole 2 litre thing is actually up in the air at the moment in terms of how much to be drinking, because if you look at a 45-kilo woman versus an 80-kilo woman and you're telling them both to drink 2 litres, you can imagine how much those 2 bladders can cope with. So a lot of the hydration strategies we look at are actually based on your body weight and your body composition, rather than just drinking 2 litres. And holding on, yeah. So yeah. That's it. And I'm getting a lot better at saying to my patients, I'm just going to go to the toilet. And I say things like, and then I can think properly with you. And then people go, oh, okay, go. Yeah, because it's really important to not hold. Because then you end up with that overactive, that holding, and then that fatigued pelvic floor rather than a weak one. So yeah, totally. Yeah, exactly. Yeah. Totally, because they can't leave the kids. They need to come up with more strategies to help with, like, female teachers go to the toilet. But we do actually go through strategies to help distract the urgency messaging from the bladder as well, so that you can actually hold a little bit longer and then go when you can. So that's something that physios will do with you. Pessaries. These are some of the many different pessaries that we use. A pessary is a support that we can insert into the vagina. I've got a picture of where it goes here. So it goes up through the vagina and sits underneath the pelvic organ. So there's lots of different types, and that's why I've got this here, because I would choose the pessary that I think was most appropriate for you based on what you're dealing with. So no. So a yoni egg is like a pelvic floor weight. So you would work on lift, relax with that, like a bicep curl. This is a support that you would put in. So a ring is probably the one I use. Oh, you can't really see it on screen, but the top left square, a ring is what I would use with most women, because there's lots of different bits you can put on it. So you can have a plain ring, or you can have one with a little bit of support in there. So that would sit under the uterus and hold the uterus in place. The knob at the front helps to splint the vaginal wall against the urethra when the bladder is prolapsing back. And then you'd use something different if the rectum was prolapsing in, and I'll talk to you about that as well. But for me, most urinary incontinence pessaries, I would be using either this or the dish. And then there's different shapes as well, depending on your vaginal length, width, all the rest of it as well. So I know I was saying to my girlfriends, didn't you? Yeah. So, and we use, some women, I'll say, I'm going to put this in. I just want you to leave it in for 3 months, come back and we'll take it out, wash it and put it back in. Yeah. No. There's lots of different materials that they use now, but they're getting really good at putting overshare, but I've actually got a pessary in today and I can't feel it at all. So postnatal bodies really like pessaries, but also in terms of pelvic organ prolapse. Yeah, so we'll do lots of testing when we do fit it. We make sure we get the right length, tension, all that sort of thing. We make sure you go to the toilet, go day to day. Yep, there's different types. So some of them you've got to take out every night, wash it, leave it out overnight and put it back in. And then there's others that you can just leave. So depending on what the patient wants or what the woman wants and needs. Yeah, so the vagina isn't this tube that sits in the pelvis. It's actually, if you think about like a sock, I should have brought a sock.
What? What?
Oh my goodness, I've talked too much though. Have a look at the time. Ooh, I'm almost done.
Can hear you now.
Mm. Thank you. We just got a new battery. Yeah. Where did you hear me, or what did I finish with before I cut out? The
It was
sock.
only a couple seconds. Yep, sock.
Cool. So yeah, it sits flat. So then it opens obviously when we've got to let something through or insert it. So the pezzer is actually, depending on which one you use, will help splint it open or splint against one of the organs that's prolapsing against it. So this leads us into pelvic organ prolapse. So you can often get stress incontinence because of a prolapse. So when we treat the prolapse, the continence goes back to normal. So if your bladder, so the top right picture is the bladder prolapsing into the vaginal wall. So we would treat that with a different pessary or a different, I guess, pelvic floor cue to a rectal, which is the bottom, C in the diagram here. A rectal prolapse here is prolapsing into the back wall of the vagina. A uterus prolapse is when it drops back away from the bladder and down into the vagina as well. So it depends. Sometimes we'll have two organs prolapsing down. Sometimes all three will prolapse down. And sometimes it's just part of the lowest part of the vaginal wall that's prolapsing in. So when we assess, we take lots of different measures, and we can refer on if it's needed for surgery. But again, we have like a step-by-step process. So if I'm doing a vaginal exam, I've got the lady lying on her back to start with. When you go in, I check for pelvic floor strength, and I do all of the tissue checking for tearing and things like that. And then what we do is we actually use a tongue depressor. You know what the dentist uses on your tongue? So I will support the front wall of the vagina and get the woman to bear down as if she was, doing a poo or giving birth. And you look at what happens, and then you support the back wall and you get them to bear down and you look at what happens. And then we measure, I'll then go in to insert with one finger and I'll find the cervix and I'll get you to bear down, and I can measure there how far the cervix descends, because the cervix is the bottom of the uterus. So we can see how much change there is in your vaginal length, and that tells us how much the uterus is prolapsing down, or front and back wall. And so we stage them. Did I put that up there? No, I didn't. We grade them in terms of how far down they're prolapsing. So if I give you this picture, none of them are a very good picture, but we measure, a stage 2 is sort of where we measure from. Stage 2 is anywhere from 1 centimetre within or 1 centimetre without. So I don't like that grading. I think it should be like 2A and 2B. But anyway, that's a stage 2. And then if we come back to that centimetre within, stage 1 is within that. Stage 3 is outside the introitus by 1 centimetre, and stage 4 is all the way out by 2-3 centimetres. Your organs have actually exited the body. Yeah, they're dropping down outside the body. Yeah, which is not comfortable and not happy. And it's amazing how many women get to that point before they do anything about it. And so the symptoms of that is you'll feel maybe a bulge in the vagina. You might feel lower back ache because the uterus attaches to the back of the sacrum here and here by 2 ligaments, and it suspends. You know, I was talking about the rubber bands at the start. They suspend the uterus. So if the uterus is then prolapsing down the vagina, it's going to pull on the sacrum and create a backache. I hope I just whacked the microphone there, ladies. Is everything okay?
Yeah.
Don't touch the tech. Cool. And you'll feel like a heaviness or a dragging feeling in your pelvis. And depending on the prolapse, you might have issues emptying your bladder properly, or your bowels. It may be painful to have sex. It may be completely fine and neither of you know anything about it. It just depends. And recurrent UTIs as well with an anterior wall or a bladder prolapse is really common as well. So you don't get a complete emptying, and so there's a little bit of urine sitting in the bladder all the time, and that can create infections. So one thing that we talk to women about with toileting is actually sitting in appropriate position. So have you guys heard of like a squatty potty? You can put a step, yeah, because really humans were actually, before toilets and everything else, we actually just squatted on the floor. Yeah, they still do it. They have the lowest incidence of hip and knee arthritis, but also lower prolapse. Yeah. So what we teach people is to get that stool. I don't get people to squat on the toilet, but I get them to get a stool. Can be a shoebox, can be anything, but just to lift your feet up and angle your pelvis forwards, depending on the prolapse, but usually angle the pelvis forwards to take the pressure off. And obviously, like if it's a rectal or a bladder prolapse, you'll change the angle, but sometimes women need to sit right back to take the pressure off the bladder, and sometimes it's forwards, but usually forwards more than anything else. Yeah, so rather than, and that can help you to take the pressure off and you don't have to strain, because straining is very directly linked to prolapse as well, because you're just bearing down more than what you need to. So cool. Okay, and then again, just a side note, it can happen to women who haven't had babies. If they're lifting heavy weights with inappropriate core strategies. If you've had a chronic cough, women with cystic fibrosis unfortunately experience prolapse as well. And then constipation if you're straining too much. So we look at, again, pelvic floor muscle training, but that's not the only thing. We look at pessaries to support the organs or to splint the walls, depending on where the prolapse is. And then we look at your breathing patterns. We look at your fiber intake. If you have IBS, we send you to someone who can help you with that, because the straining of constipation or not enough fiber has a huge effect on all of your pelvic organs. So that's the toileting behaviors that I've written down there. And then appropriate exercise, weight loss for women who are 40 years down the track, 60 years down the track, and postnatally, the biggest indicator or the biggest factor in all of this is body weight, or particularly around the organs. So we will coach women through an appropriate exercise plan or someone to go to for it, to help make sure that they're taking the load off. And then obviously, if we've tried all of those things and we're still headbutting the wall, then we'll talk to one of the obs gynaes in town, and we're lucky to have some really good ones. And they will look at surgery. So I won't talk about surgery today, but that's their thing. And we have lots of guidelines to focus and talk to women about as well. Levator ani avulsion is what I talked about before already. So some of the fibers tear off the front of the bone. You can see in the picture there. What's really important to know, a lot of women think, oh no, it's only a 50% success rate. If I have it sewn back on, I'm doomed. If we actually work on the pelvic floor strength of the rest of those fibers, we can actually make a huge change to continence and prolapse. And again, depending on where the tear is and how much of the fibers have been torn off, we can pop a pessary in as well to help with that too. So that's levator ani avulsion. Unfortunately, you can have one side or both sides. And obviously our treatment will vary with what's happening there. In terms of referral to physio, you don't actually need a referral. You can come straight through the door and make an appointment, or give us a call and make an appointment. There's different ways of being billed. If you were to walk straight through the door, it's a private billing. If you have private health, obviously we can do the rebate for you and you just pay the gap. If you were to go through your GP, you can ask them to do there's two different names for it. It's either an EPC, which is Enhanced Primary Care Plan, or a CDMP, which is a Chronic Disease Management Plan. I like EPC because it sounds a bit more positive. The GP, yeah. Now, there's a few criteria that happen with it, and I actually had a GP ring me and give me a bit of a lecture once because I suggested it to the patient. And I'm not sure what the conversation was with the doctor, but the doctor, doctors never write back. They never communicate. And I got a personal phone call. So I was like, holy. So I always really make sure that people know there's criteria to meet. They will make sure that you're seeing someone else. So sometimes they'll have you'll be given 4 visits with me and 1 to a podiatrist or a dietitian or whatever it is. It has to tick the boxes. And chronicity means 6 months. So they have to have been having issues for 6 months. Sometimes they'll waive that if it's a pregnant woman and they're 3 months postpartum and that, they can see that they're in financial need. So at the moment, Medicaid rebates $54.60 towards each session and up to 5 sessions with allied health professionals. So some of the doctors are quite happy just to give me all 5, and others say, no, you've got to see multiple. So it just depends on what your GP's like. And then one thing I really recommend is trying to get in, the GP generally doesn't communicate much apart from writing the referral. There is a couple of really good GPs that I have referral relationships with, and they will at least write me a really good letter to start with. I'll always write back to them, and I usually update them as well, whether or not I hear back from them or not is a different story. But I always try and communicate, and you want to see someone who communicates with, for me, I'll communicate with Lauren, I'll communicate with their psychologist, I'll communicate with their podiatrist or whoever else they're seeing. You want to make sure that people are talking together and making sure that all of the whole person, the whole body is being addressed, and supported. Wrong button. Sorry, were we going to ask a question then?
Yeah, well, I asked you about how you do your examination.
Yeah.
Do you use a ultrasound?
I have in the past. I don't at this particular practice. The girls opened the practice about March last year. No, anyway, not very long ago. So they're still sort of building up their equipment. But gold standard is an internal exam, and I will find a hell of a lot more in an internal exam than what I will in an ultrasound. The one thing that's better with an ultrasound is looking at bladder neck hypermobility, which is a bit of a fascial defect. So it's sort of like if you start banging your head against the wall, then I'd be like, oh, okay, let's refer you for an ultrasound of your bladder neck. But everything else, in terms of even like looking at a weak versus a hypertonic or overactive pelvic floor, you can't see that on an ultrasound. You can look at bladder filling and emptying on an ultrasound too, but again, that's something that you look at as like a third line sort of thing rather than a first line. So last sort of thing to think about is benefits of Pilates and making sure that women's bodies are being given the support through exercise, not just being beaten down with exercise. So a lot of our female mindsets are gotta work hard, and then we go home and we're parents, and then we don't sleep until whatever time because we've sorted out the family, and then we've sorted out work, and then our stress release is to then go for like a 20K run, but that's actually, there's no rest and recuperation and support of the body and the joints. Whereas Pilates is that. I tell people it's like the lubrication of your joints, and it's a body mind exercise. It's low impact. You can increase the resistance as you're able, as your instructor is looking at your body, giving you feedback. Okay, yes, try this harder one. No, come on, regress that. You're not doing that appropriately. Whereas at a gym class, you're not going to get that. I love Pilates because it helps to rewrite the movement patterns. You get put in a position that you're not in all day. Your brain isn't quite as able to just grab its normal strategies. You sort of you slow down, you connect with your mind and your body, and you start to recruit some of those deeper muscles and the slings that are really important for stabilizing and supporting our female bodies. And I find most Pilates instructors are body nerds like physios, and they love, they're always doing this course and that course, and they're much more qualified than, oh yeah, we've had some nerd sessions already, haven't we? Yes. Yeah, and fascia is what's in your like pelvic organ ligaments that then interconnects into the pelvic muscles, and like it's the whole body, obviously. Like you've got fascia that connects your head to your toe, kind of thing. Yeah, yeah. If you think about the sausage analogy, it's the casing, but it's also running through the sausage and then connects to the next sausage in the chain sort of thing. So you can change someone's headache from their foot kind of thing. So yeah, you can really, that's another workshop. Yeah, so that was my half-hour spiel that's gone for an hour. So apologies for that, guys. But does anyone have any questions for me, whether or not it's through the computer or? Oh, cool. Awesome. Cool. So any questions in-house or on the computer, at home, in your lounge rooms?
I just was wondering, so can you do more damage by doing high impact exercise?
Only if you haven't built up the right foundational patterns. So if you know how to lift your pelvic floor against that downward pressure of whatever it is that you're doing, no, you won't be doing more damage. But if you have an organ prolapse that you're not aware of, and then you go for a run or you do lots of skipping, and then yes, yeah. It's rare, but we have seen traumatic pelvic organ prolapses where a woman's been doing lots of gym training and she's never had any sort of issues, and then all of a sudden she puts too much weight on the bar and it's a traumatic donk of the pelvic organs, and that is very traumatic for brain and body. But usually it's an overtime sort of thing that you'll experience.
Yes, like I have a prolapse, but I'm doing high impact CrossFit.
Yeah.
But and I know it's happening.
Yeah.
So yeah, do I need to stop and go low impact and get some treatment and strategies?
Yeah. So I'm always I always avoid pulling people out of what they like doing, because exercise is the most important thing for humans, particularly women, to be doing right up until the day they die. So I don't want to say to someone, no, don't do the exercise that you love, do this instead. They might hate swimming and they really want to do weightlifting. I would be modifying what you were doing in CrossFit, and I would be maybe scaling back some of the weights until I watched. Yeah. And so, yeah. Yeah. So if you came to see me, yeah. 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 It is. Totally.
But I still run. I just
Yeah.
run.
Yeah. And one thing I would say to that is that you,
Always thinking,
what am I doing? Yeah.
something going to come further out.
And it could, if you like, what I would say is come and see me for an assessment, because then we can look at those activities and say, well, no, you need to do this instead. Yeah, not necessarily though. Like it might just be maybe walk until we build a bit more endurance in your pelvic floor, or maybe don't do the deadlift, practice squats, and then we can build up your pelvic floor endurance. And change the way that you're breathing while you do it. And then you can come back to the exercise. So it's never like, no, you can never do that again. Or for some women, it's like, okay, you just need your pessary for your CrossFit, or you just need your pessary for your run. And then you can take it out and you're fine. Like you can cope with day-to-day loads, but you just need that little bit of extra support for the, yeah.
Then if you have that in,
Yeah.
are you doing then exercises to build around it?
Yes. Yeah. Yeah. You'd never just stick it in and leave it.
You can get rid of that.
Yeah, absolutely.
Muscles will be strong.
Yeah. Yeah. Yeah, definitely. No, that's right. And there's, look, if it's an 80-year-old woman, we would just give her one that she can just leave in and just come back and see us, and we'll clean it for her and put it back in, sort of thing. But for women who have the dexterity and have the ability, you can take it in and out for just your run, or you could leave it for 3 days, wash it, put it back in, that sort of thing. So there's lots of different types for different women. So yeah.
What's the not being able to hold you in? There was a
Flatal incontinence. Yeah. Flatal incontinence. So so
So what is that thing?
Yeah, it is a thing, definitely. And it is associated with those third degree tears because it can affect the like the anal sphincters. You can also relate it into like dietary sort of stuff and IBS and things like that as well. But it is that if we go, oh no, I don't know how to do that. If you think about if you're looking at a pelvic floor and you've got urethra, which is where the urine comes out, you've got your vagina, and then you've got your anus, it is a part of that anal sphincter ability to close. So when we teach pelvic floor contraction, the whole levator ani group, that deep group, attaches to the tailbone through here. And then it kinks. This is actually a nice angle. So it kinks upwards. It lifts from the tailbone. Let me see that way. Backwards. From the tailbone, forwards and up towards the front of the pelvis. So if we're looking at that, and a lot of women think that they're lifting their pelvic floor by squeezing and stopping the flow of urine, but that's only the front sphincter muscle. So it's probably a bit less than 30% of your closure. But a lot of women do think that that's all that you do for pelvic floor lifts. But then you put so much pressure on your abdominals and your organs when you're moving, and then you've got wind to hold in, but you've never strengthened or tried to lift from there. So it doesn't hold as well as what it could be. So a big thing, again, in what I would see with my patients is that they just haven't been taught how to lift their pelvic floor. And all we need to do is just show you, and then you don't have your flatal incontinence, or you don't have your leaking or your prolapse. So yeah, a lot of it is just education and knowing your body and being able to use things properly. I actually didn't bring very many. I forgot. I've got 1, 2, 3, 4, 5, 6. Yeah, I mean, you're welcome. Anyone's welcome to take one. Yeah. 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 And so that's the sphincter around vagina and urethra, but that's got nothing, it's not using the back of the pelvic floor. So you're really not getting an appropriate pelvic floor contraction at all. Yeah. So, yeah.
There's a few more here anyway. Any questions from the people at home?
Yeah, anyone on the computer? Can you still hear me all right?
Yes.
Okay, great. Does anyone have any questions at home or the information overload? Yeah. Yeah, cool. Yeah. Great. Yeah. Yeah, and so sometimes when it depends on what surgery you had, but sometimes it can actually uncover an underlying issue. So when the uterus is prolapsing down onto, and I'm not sure what your prolapse was, but okay, all right. So the bladder was prolapsing back into the anterior wall of the vagina. Does that make sense to you? So your bladder sits in front of the vaginal wall, and then the uterus sits on top of the bladder like that. So they removed at that time, or did you have a hysterectomy before? Ah, okay, great. Thank you for that. So what happens is that the bladder is prolapsing back onto the vaginal wall. So did they use slings? What did they do? Stitch it to the front of the pelvis? Okay, cool. Yeah. No, they don't. Yeah, and look, depending on which surgeon you saw, if they were local or not, if they referred for treatment, I could easily ask them for like an overview of what, or at least the name of the procedure that you had, and I'd be able to answer a bit more clearly. But often what will happen is that when they then stitch it forwards again, they could change the angle of it so that what was happening with the bladder was it was actually creating a bit of closure. And so it was giving you like a passive closure. And so when they put it back into position, they're uncovering a weakness, A, in the pelvic floor, or B, in the urethral closure. Or it could be that you have bladder neck hypermobility. So the bladder neck or the urethra can actually be really distensible if you have, say, a history of hernias in like males or prolapses in females in the family. But yeah, often lifting up the structure that was creating a passive closure can actually just show you an underlying, like I said, a weakness in pelvic floor or something else that needs addressing. So yeah, it would be worth assessing and seeing what the driver is of that too. Yeah. Yeah. Yeah, so I would say that prolapse was actually giving you that splint against the vaginal wall to give you that closure. And now that they've taken that pressure off, yeah, maybe some pelvic floor strength would be enough to get rid of it. So, yeah, just and a prolapse severity, yes, we can grade it, but it really, the severity is dependent on how much it affects your life. So some women will have a prolapse that's like borderline grade 3 or 4, and they don't care. They don't even know about it. And so are we going to treat it and put them through exercises and putting pessaries in and things? Probably not. If it's not affecting them and not upsetting them, there's no need to. But some women can come in with a borderline stage 1, 2, and they're like, everything's falling out. I feel a bulge. I feel so uncomfortable. My back hurts. And you're like, well, yeah, we're definitely going to change. We're going to do what we can to treat that. So yes, we can grade them, but it's all about the person that's sitting in front of you as well. And you know, if it's not bothering you, then yeah, if you can go through life and you're happy and functional and it's not creating any boundaries or yeah, limitations, then that's good. Mm-hmm. Mm. Yeah. 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 Cool.
So Hayley, are they as qualified as a women's health physio to help with the exercises and the retraining? That's sometimes the thing that you might think you're going to, the right specialist, but you're not.
Hmm.
Like,
It depends. Yeah, and yeah, like I can't comment on the professional that Helen saw because I don't know who she is and what she's done. But the other thing is that some specialists specialize right down into the pelvis and they don't look above. So it might be that you're bearing down from your abdominals and putting pressure onto the bladder that way. That, you know, if we change that, that would change the amount of pressure that's going down and any leakage there as well. And because physios, we all have to train in the musculoskeletal world first before we specialized. We tend to have a bit more of a whole, or if not whole body, at least whole trunk sort of view of it. So yeah, yeah, I can't comment on their skills or anything because I don't know who it is. But yeah, question here. Yeah. Yeah, great question. Um, it depends on the person and how. Yeah, yeah, definitely. You should start to see some change after a couple of weeks. So usually, I won't book another appointment if I saw you for your initial and I gave you some exercises to do. I'm not going to see you again for at least sort of 3 weeks because you're not going to really see change until that 2 to 3 to 4 week mark, really. I mean, some women, it depends on what we do. Some women, like this other, I had a patient on Wednesday who had a pelvic organ prolapse, and within 30 seconds of me teaching her how to use her pelvic floor, we then did another squat and she was like, well, that feels different. So it depends on what we're doing as well. So the strength side of things, it'd be a few weeks. If it's just a strategy movement re-education thing, you'll see it straight away. You'll see change. And yeah. Yeah. Yes. It's not a bad thing. We have to do it. It's the most amount of pressure. Yeah. 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 Because most women bear down when they stand up. They hold their breath and they bear down on the pelvic floor. And when I say women, I mean men as well, everyone, because they don't know. Yeah. So you need to breathe out as you stand up and you're going to get a natural lift of the pelvic floor because diaphragm and pelvic floor work together. So inhale means descend, exhale means contraction and lift. So even just teaching people to exhale on the stand up is going to make a change. But one thing I try and get people to do when they're sitting as well is separate their sit bones out so that your pelvic floor is in a nice like length and tension to be able to contract itself as well as possible. So every single person I get, I'm like, wiggle your sit bones. If you don't want to get your hands under, totally fine, but just wiggle so that you're nice and sort of aware of pelvic floor. And we've been sitting for over an hour now. So you can, you probably got a little bit of urge to go to the toilet as well. So you've got more feedback. I know, take a turn. I went before we started. So then you lean forwards and you take a breath in. Find your feet, so find your heels in particular. And then as you exhale, you're going to lift your pelvic floor from your anus, like you are trying to hold in a little bit of wind as well as stopping the flow. And you'd exhale and stand up. So one of the things I say is nose over toes. So you want to be in that forward lean first so that you've got the access to use your hamstrings and your glutes as you stand up. Yeah. No worries. All right. Is that all the questions for now? People at home? Yeah. No, education is power, isn't it? Yeah. Yeah. That's it. And Teresa's coming to my pregnancy class too. So she cops all of that information all the time. Cool. All right. Everyone's.
Anyone else got any questions from home?
Oh, anyone else questions? I did ask. I don't think I've got 2 muted ones. I think they've self-muted though.
No, but they should still hear you.
Yeah. Yeah. Okay, cool. All right. Well, thank you everyone for coming along.
Ladies, if anyone would like a bit of afternoon tea, it's ready for you in the kitchen. You'll have to rush off.
Sorry for running over.
Have something and still chatting.
It's a celery juice. Thank you. Thank you, Kirsty Lee. Thanks, guys.
Thanks, nice and
All right.
I'm
And
just going to stop the recording now.
I'll let you touch that.